All right, it's about time we get started. My name is Brendan Taylor, and I'm introducing Dr. Cai. The Center for Integrative Environmental Health Sciences and Department of Pharmacology and Toxicology welcomes you to our Environmental Health Science Series seminar. Today's speaker is Dr. Lu Cai. Dr. Cai received his MD in 1983 and PhD in 1990 from Jilin University in China, which was formerly known as Norman Bethune University of Medical Sciences. He has had his postdoctoral training in the University of Western Ontario and McGill University from 1993 to 1999, and pharmacology and in Canada. And Dr. Cai is a tenured professor of departments of pediatrics, radiation oncology, and pharmacology and toxicology, and is the director of Pediatric Research Institute and the University of Louisville School of Medicine. Dr. Cai has served on many special grant review panels and committees at the NIH, Department of Defense, American Diabetes Association, and American Heart Association. He is the author and co-author of more than 360 publications, including peer-reviewed articles and/or book chapters and such. He is editor-in-chief of Dose Response, World Journal of Diabetes, associate editor of Journal of Geriatric Cardiology from 2011 to 2015, and of Toxicological Sciences from 2014 to 2019, and as well as Rad Med Protect from 2020 to current, and Frontier in Endocrinology with a specialty in cardiovascular disease from 2021 to present. So without further ado, we have Dr. Cai.
Thank you very much, Taylor, and for the nice introduction. And actually, I already covered my slides almost. Thank you so much. And also, thank you everybody here and for this attend this seminar and some in the online. And before the presentation, I want to see what is the purpose for this time. And because I worked here for a long time and I did some specific topic for everywhere, several places for many times. And recently, because the P30 is reorganized the research interesting group, and we saw the new group have new people and is from different part of the campus and in the medical campus and also the main campus. So I think probably, and because like a couple of years, we're building some collaboration with different departments, even main campus. So in order to give you some more idea what I'm working and in the field and what is the topic and what is like my background. So in that case, probably you're easier to memory or some part in Lu Cai's lab, probably we can do some collaboration. So that is some main purpose for today's. And so in that case, I want to, based on my training and the background, to relate it to some three fields, three areas. One is low-dose radiation, one is environmental toxicology, and one is diabetic cardiovascular complications. So Taylor already introduced my background. I got training from like medicine, radiation, biology, oncology, and medical toxicology, and reproductive toxicology. And probably this one gives you more idea and what is the life and our journey for my research career in the North American. So in 1993, I went to the Canada in the Western Ontario and University of Western Ontario, right now they call it Western University. And I worked in there and in like 1.5 years. And I moved to the Montreal in the McGill University, work on reproductive and toxicology with Dr. Louisville and Barbara Harris and Fernando Louisville, and both work on the reproductive system. One is work on the male and one work on the female. So that is give me more benefit when training got both. And so that is after that in the 1997, I went back same lab with Dr. George Cherry, and he offered me a research associate position in Canada. That is kind of the job, it's not training for fun. So I continue work on the metal So in 1999 and November, and I moved to here and work in the Department of Medicine. And so until in 2008, and moved to the pediatric department and work in the Pediatric Research Institute. So that is the kind of my journeys. So based on that, and now I want to give you some idea of my first interesting field, low dose radiations. And my PhD thesis that is published in 1990. That is my first English publication, and after I finished my PhD training. So I work on the low dose radiation and in the genetic and cytogenetic in the male germ cells and somatic cells. And meanwhile, also work in the other project regarding DNA repair as a background. So after that, and so that is I focused on the radiation biology field and have several years work on that. And since then, I'm really interested in this field. So in order to give you some rough idea, and I want to give you some idea what is the radiation, ionizing radiation, and non-ionizing radiation. So radiation is have the highest Hertz frequency and highest the energy compared to these spectrums in the last part. And how ionizing radiation works. And usually it's a particle and through the molecules and probably makes and the heat makes some power, make some electron from the inside to outside layers. That is kind of excitation, and that molecule still stable, just release some heat. So that is called excitation. But once the particle is strong enough, make the electron off from the atom and called the ionizing part, and also the electron off from the molecule and make that is kind of losing lose one electron. So this part, this action called ionizing radiation. So why that is dangerous? Because that is the form the atom or atom or molecule become free radical, losing one electron, try to go around to grab other molecule for the electron, make themselves stable. So that's why that is a very active damage from the neighbor cells. And for the ionizing radiation damage for the molecules is a more dangerous part is for DNA. For the chemical, when we got chemical exposure, the go-to system, metabolism, go to cells through the membrane, go to cytosol, or it's possible to go to nuclear or not. So that is depend a lot of that. But the ionizing radiation just goes through whatever direct hit nucleus. And if got a direct hit DNA, cause that the ionizing electron off, cause that molecule or DNA damage. And if not directly for DNA, that ionizing water in the cells and makes the water a secondary generates a hydroxy free radical, cause the same damage. So that radiation can directly damage the DNA and also indirectly damage the DNA. So that is the powerful for DNA damage by radiations. So DNA damage, genomic damage, and the outcome is cell death. So that is the principle for radiation therapy, because we try to kill the cancers. For example, if the patient and they have radiation, they try to kill the tumors. They use different dose depending on different kind of tumors. And leukemia very lower dose, and you see less than 20, and other is 50 and 60 agree. And I can use this one to demo. For example, we try to kill the tumors. So different dose based on different tumors. Why we have the dose limited, not go to the 60 or the 70, go to 80, 1000 degree, because that is a dependent. The radiation also have some backside and back side effects for the other normal tissues that causes the radiation sickness. And so the dose is a pickup that is dependent on the normal tissue tolerance dose. And currently, we found the higher dose one time, it actually is not that efficient. And if you use a fraction radiation, then more efficient. Why? Because the tumor cells proliferate faster than the normal cells, and the cell cycle only M phase, and G2 phase is most sensitive for radiation induced damage, because they are already after the DNA repair and synthesis that is loose without any repair mechanism. So one dot of radiation that damage the DNA, no repair, and go to next cycle, they will die. So that is like why we use a fraction of the radiation and protect the normal like T cell, because that proliferates very slow, not like the tumor cells. So that is one radiation work on like that. So I talk about the degree, and probably you're confused what degree means. So for the radiation, they have 3 different kinds of those terms, and usually it's like from physics and the chemical like terms, they call it Roentgen. So the R, that means the air dose. It's not go to biology bodies. But once you go to the biology body of some dose, that called the Gray or Rad. And so when they count the different organ, they call it the equivalent dose. So that is called the silver. And so that is like usually this is the common use like dose term. So 1 gray equal 1,000 milligram, and so this is kind of the term. And what dose radiation is safe? And from theory, no safety dose for radiation. And but the dose lower than 100, like 100 milligram or 0.1 gray, actually you cannot see the symptom. Even they still have a molecular level damage, kind of DNA damage. But our body have a lot of repair functions and defense functions. They remove the damaged DNA. They eliminate the cells with the genomic damaged cells. So that's why you cannot see the symptom lower than like 0.1 gray. And so my field, I work on the low dose radiation, actually much lower than 0.1 gray dose. And here I want to give you some general concept. So the radiation induced any damage that it can increase the curve and some inhibition or shut down some repair activity to go down the curves. But all the data is come from the high dose, higher than 50 milligram, and the levels. They show the linear dependent. But for the lower than that, actually they have no idea and just kind of extrapolate and based on high dose and go to the 0, and they call it the linear non-threshold principle, ran by the radiation protection and uses the principle. Is that true? But that is my field work on that. So a long time ago, and one study, they tried to look for the very low dose environmental situation to see their tumors, but they didn't see the tumors, but they see the longevity is changed. And you can see, and this is the female, and they can survive 800 days, not big difference, not reduced. But in the male, they're alive, shorter than female. But if you have the low background, low dose radiation, that enhance or increase the longevity. So that they call the homeostasis. And so after that, and I also joined this field and work on the low dose radiation, I gave example already, and that is my PhD project. So later they have a lot of information, low dose radiation turn on and stimulate the antioxidant and some repair mechanism. And myself found the AKT nerve 2 and upregulate. And so basically that is not a linear non-threshold. And actually like this, they have a bump or stimulated part, either called the U shape or a J shape. So that is the dose response for very low dose field. But currently the protection agency still use a non-linear threshold. And because that is the lower dose range is difficult to generate a human state, very difficult. So that is still an argument. But I'm not involved to argue that question with a protection agency. I want to look for what is the beneficial phenotype. The low dose radiation turn on the homeostasis. What's that going on? What is the for the cells next? So we think about that in our lab. You never only have one hit, right? And so we think about probably you've got low dose radiation. And so you will have some mechanism there. What that affect for the second subsequent high dose radiation or chemical induced damage? So come to in 1984, and Dr. Sheldon Wolf and working in the California area, and he has a smart idea and treat the lymphocytes in vitro. And one group is give the ceridine and in the medium, give very low dose and kind with radioisotope to treat for 6 hours for the lymphocyte, and then both give the high dose 1.5 degree to treat it. And you can see in this group. In this group, actually the additional sending and reduce the low dose not enhance the damage, actually reduce the damage. So they called the cytogenetic adaptive response. So that is published in 1984. My publication is in 1990, so 60 years later. So while I work on the project, also that is the in vitro, and I want to see the in vivo. So for example, you can see that 75 milligram low dose group and this is high dose group. And if we expect the expectation, suppose this one plus that one, for example, with this, then but the date is from significantly reduced, much lower than expected. So that is we also called the adaptive response in the in vivos. So after that, and we come the mechanism to see, and because the first low dose radiation and turn on multiple mechanism and make the the cells more tolerant and strong against the next high dose chemical caused damage. And the mechanism right now is more epigenetic, microRNA, a lot of the information there, but at least some mechanisms there. So, and here for the human and the population, and I want to give you the idea of what's going on from the low dose radiation. And you know, our United States, different states have different geography, and Charlie knows that as expert. And but the one study they look for the in Colorado area, they have a radiation isotope waste to bury in that field. So make that and the area they have a high natural background radioactive activity compare other states, compare Kentucky where we are. And another is they look for the lung cancer in each state, and 100,000 people, how many lung cancer. And you can see from low to high, and Kentucky is high, even we don't have the high background radiation. So we have a highest and the lung cancer frequency or incidence. And for this, a couple of states in here have a high low dose radiation background. You can see that belongs to the lowest lung cancer field. So we cannot see that the lower lung cancer is derived from the low dose radiation stimulation, but at least this is kind of geography or epidemiology work on what is the association, what is the positive association or negative association. So if that is true or not, this we need a further study from the lab. So this is the conclusion, and that really reduce the lung cancer incidence. And for myself, I'm not working in the cancer and the population level, and I work in the lab, and I got invited to have a review or comments and for that journal, Human and Experimental Toxicology. And one part I've discussed, can we think about the adaptive response and use the clinical to have some benefit for the patients. So, and about 10 years later, and we found probably that can use prevent or treat for the diabetes or complications. So in Japan, they have used the low dose radiation, give ras and mouse pre-exposure, and then use STD or alloxin to induce diabetes. Really shown the low dose radiation reduce the STD or alloxin induced the diabetes. But that is not like a practical to apply to a population. So I think, and the complication probably have a better idea. When you got the diabetes diagnosis, you'll definitely have some complication. If this complication, the low dose radiation really have that benefits, probably at least it's better than prevent diabetes. So I work on that field and use a different organ. We found some like a very promising data. And we also work on a collaborator in the hospital. We try to look for how the low dose radiation stimulation and using clinical for cancer therapy. And so in the world, they already start thinking about the use of low dose radiation background. So in the United States, and the example is Walter, Montana, and they open some the cave. They have a high background radar, and they set up the kind of the office, enjoy, and have a little warm. And they, like Japan, they have some like hot spring, something like that. And so treat your chronic inflammation disease like atherosclerosis got significantly improved. So that is kind of applied. And in the pandemic period, and I work with the director and for the radiation oncology, and we think about the low dose radiation treat the COVID-19. So that moment, no efficient treatment approach. So we think about that because that is just a hit, and inflammation cells and is sensitive for the radiation that comes from immune system, immune system. So it is sensitive for the radiation. If we give the radiation treatment in the lung and shut down the inflammation storm and prevent the acute inflammation cause a problem and can slow down the inflammation, and low dose also stimulate other immune or repair mechanism. And so we talk about that and through the different mechanisms. But right now, really have a lot of the country and even the United States and Ivory, they start a clinical trial and do the COVID-19 treatment by using low dose radiation. So this one is shown and like a promising comment. For example, 33 patients and 32 and not low dose radiation treatment. Both they have COVID-19, but in this group, you see they have like an unfavorable outcome or less, and in this group, and they have a higher. So based on the population or clinical trial, really shown the promising low dose radiation treatment. And bottom line, and they didn't see any radiation related to side effects. So that is because low dose radiation emission even have some damage, but our body to limited that, so you don't have that much worry. And this year, and we saw that based on my previous research, and we think, and the problem also is promising for the Alzheimer's disease. And because Alzheimer's disease and no efficient medicine to work, and also because the medicine, all the medicine you go whole body system through the blood go to brain and wear less, so that's probably not efficient. And radiation can directly irradiate your head, and 80 or 70 years old, and you don't worry about 30 years later about radiation-induced cancer. But as long as you can improve the life quality, that should be very good. And you see, this year they also have some other system review. It's very positive. So I want to give you two real samples and examples. So in Canada, and one gentleman working on this field is Dr. Carter. What time right now? And he worked on the low dose radiation. And one day, his friend and talked with and with him my wife got Alzheimer's, and we use all the approach medicine, basically not to improve, and worse and worse. And in Canada, and the health insurance is very good. As long as you can stay hospital, your CT is free. And so they think about using CT for treating the patients. So they give the patient, and you see multiple times CT. One CT is about like a 40 milligram, like the dose we use 75 or 50 milligram. And so you can see they gave that twice, and that at the beginning, and then at a couple of months, and get about one CT. And this patient got significant improvement and compared to before. Even you give the pizza, and she loved pizza. When you talk with her name and have some response for you. And but after 2 years later, still kind of passed away, and so nothing is forever. But at least improve several years quality. And right now they are allowed to do clinical trial, and so in the NIH they have another 4 patients and clinical trial right now. And the interesting, her husband is a Parkinson's disease and always shaking. And once he saw his wife got that significant improvement, so he also volunteered to start to eradicate by CT, try to improve the Parkinson's disease. So that is like how I work on this like journey, and for the low dose radiation at the beginning for the phenotype and the mechanism study, and then later to think about how to use the mechanism and principle to clinical application, gradually have more potential. I cannot see tomorrow immediately apply, but at least I'm very enjoying that. So for myself, I also have some reward. And so I got the career development achievement award in 2008 by the Society Dose Response Society. And so that moment I'm very young. So and I also in charge of the radiation biology teaching for the our university radiation college residence program, and start from 2007, more than 15 years already. And before a group, and even Chris also joined that team. But later they don't have budget. They only teach myself. So I have 9 or 8 lecture. Each lecture have 1.5 hours right now to take care of the teachings. So I also relate to this and become the deputy chief editor for the radiation medicine and protections. So I enjoyed my journey for that. And so now I want to share my experience and the feeling for the second part for environmental toxicology. I start and that before I moved to the Louisville, and my previous boss in Canada and McGill, they work on a toxicology field. So you can see my first publication is work on the copper and iron induced the DNA damage, how microcyanide protect that. Because we know microcyanide is a metal binding protein, probably can show some protections. But we found, and so you see, this is without MT, and this is a self-resistant radiation can induce not copper and iron can induce some amount of DNA damage. When we gave that in the system have MT, and for the copper induced DNA damage got significantly reduced, but not in the iron. And because the microcyanide, and this is the microcyanide 63 and amino acid, and have 1/3 is a cysteine, so they can remove a lot of the free radical and binding metal. And more important is the microcyanide binding copper most strong binding zinc. So that means in the system and zinc MT in here, and you see zinc MT binding copper release zinc. So that's why it reduces the DNA damage. But iron is very weak binding with the microcyanide. So that in the buffer, the same system and the microcyanide not binding iron. So I start from there and start working on the mitotoxicology and work on in the McGill. I work on the germ cells and other anti-cancer drug damage. So we work the apoptosis that age, and that's a long time ago. You see, And we do not have a very sensitive method to detect the apoptosis. And you see, this is a very low frequency. And in the control, occasionally you can see 1 or 2, but after cyclophosphamide, and you can see a lot of the apoptotic cell death in the Patagonia state, very sensitive period. And in that lower apoptotic tissues, using regular DNA lighters, I cannot see any lighter because that is been diluted. So I have to use a radioisotope label the enzyme to conditernal in the last part with the not the enzyme with the radioisotope. In that case, and you prove that method, you can see that clearly the lighter is shown up. So based on that, I learned a lot of technique and some new idea in there. So after I moved to Louisville, and we know, and Louisville has kind of some contamination. And when we go to the EPA, and you can see they have a pollution, air, water, land, and affected human health. And you can see that in the blood, and the cadmium is in the top. So we think how to work on the cadmium. And the traditional way, we not only think about some single period. And for example, most times they work on the adult animal or model, they will be short, acute, and chronic exposure. And occasionally someone work on the embryo stage or the postnatal period. So, but now have the new ideas, exposome. So that means you are not only work on the adult period. You need to think about whole life spectrum. And so for my cadmium work, and so we are not only work that and think about the whole life, and also think about the partial for the prenatal and exposure, and that how affect the adults. So, for example, I work on the cadmium exposure in the adult period and give a 4 weeks treatment and look for the very late state and without washout to see how the persistent latent effect. And we this is a scale, and we work on that model, and we work on the proteomics level and to see what's going on. And we use the dose very low, and so that is some data. And I only want to show you one. You can see this is already after treatment 20 weeks, and the cadmium is still higher in the liver, but 40 weeks, 52 weeks, and you can see slowly down and close with control level, but still higher than control. And meanwhile, they also affect other trace elements, essential metal like zinc, and that is a very long time to can catch up to normal level. So that is some my work for the cadmium, and we learn a lot and different kind of outcome. But one interesting part is we know this is the one apoptotic cells pathways, and TNF alpha and phospholipid turn category 8. But we found the low dose cadmium. Sorry, go to radiation again. Low dose cadmium and exposure, they have caused the hypomethylation for the TNF alpha. That means the expression of further increased. But got the hyper higher increased hypomethylation and makes that category 8 and the expression lower. And so in that case, if our body cadmium still causes the DNA damage, and but without apoptotic cells death pathway, so that means our body has the cells with the genomic damage, but cannot remove by apoptotic cell death pathway. So that is a very high risk for the cancers. So that is we confirm that mechanism. We use a methylation inhibitor to see the data, and you can see the one convinced data is that cadmium increase the caspase 8, and if we use methylation, that is done, and that is methylation part. So that is convince and our ideas. So the detailed data and the too boring and just pass, and we do different measurement, and we found that is a single chronic and the lower dose cadmium did not induce some acute response like a high dose and exposure. But even that environmental level that low, they still cause some mild, persistent, and like damage, and from methylation levels. But that is the single measurement. But we want to see, and how about the our life, because in our life always have A and B. If you only work on A, you didn't think about B, and you didn't see that phenotype. So in that case, we know the human have multiple, and Kentucky we have obese, and so high the residence. So next project, we want to look for the prenatal exposure, the low dose timing, and they give high fat diet for the mom and the offspring to see what that the effect. So that model will mimic our real life. So that is give you some idea why we think about prenatal exposure, because a lot of the human disease is based on from the children that turn on some epigenetic mechanism. So in this model, we give the whole life and the timing treatment, and then we give hepatitis treatment after the weaning. So that means 2 hit and a different period. So this period is based on mom and got contaminated or not, and later life, and if environmental individual also got exposure, and so have the so we published that and several results and work, and we found in the heart and in the liver and cause the problems. So that shown the synergistic effect. This is the one and outcome, and we found that the high fat diet and high timing diet to go through this pathway got a lot of the and protein nutrition increased. So that is some one project. So this one they found, and so similar, and work on cardiac, and they found high fat diet and induce this pathway predominantly based on this measurement, and high timing alone based on this, but not significant phenotype. But if combined, you can see the multiple mechanism pathway make that is a symptom significant sum up hypertrophy or dysfunctions. So we also work on the model and only maternal exposure without the individual alone. So that is timing exposure only this part, and then in the upstream period about the second hit without timing. And we found that the cancer liver also significantly increased, and the number and the size, and so that is from the HCC induced model, we found that the phenotype is significantly increased, and this is a pathology to look for mechanism, and so that is one model. So based on the timing model, we really learned if you work on the one compound, even radiation, low dose radiation, and the timing, there is probably you see nothing. But if you have another factor, hepatitis, and if you without timing treatment, hepatitis also have some 6 months, you see some more phenotype, and very slow and very lower phenotype. But if combined, our real life, that is something amplify the signals. So the model, when you work in the lab, you need to think about what is the more realistic. Like right now, to emphasize the exposome, gender, age, and multiple mixture and exposures. So same thing, and I work on this field, and also enjoying that. Got several awards, and you can see that in 2020, really kind of very excited. I got several awards for that, and also involved some staff from the joint editor board. So I really enjoyed that part too, and it gave you some idea how we work on the toxicology field. So the third and the direction, we work on the cardiovascular complication of diabetes. So that probably you know more, and you heard in the Lu Cai work on diabetic complication, but just give you an example for diabetic cardiomyopathy. And because I moved to Louisville and as a research associate in 1999, and I become the faculty and in 2021. And so that moment I start work with James Kang and work hard. So I picked up the diabetic cardiomyopathy, and you can see that moment not that much and diabetic cardiomyopathy, but based on that literature, we found that oxidative stress plays a major role for the diabetic cardiomyopathy, and because of mitochondria and dysfunction reduces superoxide that generates a different downstream free radical causes the damage. So based on that, and we know the oxidative stress is very important for diabetic cardiomyopathy. How we prevent that? And traditional use of vitamin E, vitamin C, and it's not works because that only work in the one part, and either here and either downstream in the very end part. So that is too late in the stream and the network. We should in the early stage remove free radicals. So and we need a new antioxidant and not in the specific one part like SOD or catalyst, and we need some diverse and non-specific efficiency. So we think methylcyanine is the one good candidate and have a small peptide, strong antioxidant function, and they can remove all the free radicals. But so I want to ask is MT can protect heart from diabetes? So that start from 2001 and 2002, I work on this field. So you can see we use first we try to answer is the diabetes really cause cardiac cell death or not? And what are the cell death pathways? So we found that is from mitochondria and oxidative stress. And later we also use the cardiac myocytes overexpress MT model and work on that, which shown the MT work on the top to reduce remove that pathway. So based on several specific projects, we understand methylcyanine really protect heart from all the levels and to show the protection from diabetes. And how about in the humans? So I collaborate with collaboration in China and in Chinese population, we found that if MT gene mutation have high risk for diabetes, high risk for cardiovascular disease, and more makes me convinced. And at the same time, in Italy, and they published another work, same year, same month, published same date. They use different population, and they found the methylcyanine mutation, and they have a high risk for cardiovascular disease and have diabetes risk. So that means convince me what we found in the animal model really have some clinical relevance. So based on that, I have more kind of encouraged and encouraged. So we work on the mechanism to see how MT protects the mechanism part. And but from the literature, we know MT can remove all the free radical, but only that part pyrokinetics is no evidence. So by myself work, and we found that it really can scan pyrokinetics. So I answer that. So in that case, we fully work on the mechanism, and we found that it's from pyrokinetics and reduce the apoptotic cell death and prevent the cardiac dysfunction. And we also look for other cofactor like AGN2. For example, we gave the short exposure and then remove that and to see what the next 6 months later what's going on. And what we found the methylcyanine protect part from the AGN2 or diabetes and reduce the apoptotic cell death and prevent the cardiomyopathy. And later the postdoc work on the pathway and Pharm GSK involve that pathway and anti-protect that. And later we further go to AKT levels, and we found that diabetes more specifically inhibited the AKT2, and the MT can prevent the AKT2, and that makes the whole system not protect. And that study reminded me ask how important AKT2, and that is is true. We found in the animal model, and we look for the literature, and they already see if humans they have AKT2 and this deficiency, there's a Shawn type 2 phenotype. And so even though recent years they still work on this field, AKT2 mutation or have some different patterns. So that really indicated AKT2 is very important. So we combined crossbreeding the HT2 whole body HT2, and with the mouse and have a heart, have MT overexpressed. So in that case, we have the mice and whole body without HT2, and only have an MT in the heart to see what's going on. And 6 months later, so we can see, and this is the normal insulin pathways. And HTT in the heart, they very important glucose metabolism mediation, regulation. And one and HT2 knocked down, and the body shown compensated HT2, HT1 increased. And so, but HT1 makes the animal survive, but a long time they shown the complication called collagen formation, inflammation, and the insulin signaling pathway called kind of is lower than wild type. But when we give the HT2 and the knockout and cross-breeding with the MT overexpressing heart, and you can see that the HT1 kind of the compensate increase is gone, and only MT in the heart without HT2 still makes the complication significantly reduced, and insulin signaling close to the very normal. So what is going on, we don't know, but that is like the phenotype we found. So summarize that, based on MT, antioxidant pathway and glucose metabolism, and MT, it really can preserve the function. How, and we want to, like how they go through that pathway, we don't know yet. We want to go to mechanism study, but we already think about the application clinical. So we use the zinc to induce MT to see how protect heart from diabetes. And we published that in Circulation in 2006, and we found that protection is through the MT. And immediately in 2007, and the clinical study, they look for the type 2 diabetes, and they look for zinc levels. So they decided one is the group lower than 14, one group is higher than that. And they found that if zinc lower than 14, and they have a significant cardiovascular complication compared to like the higher. So that means confirm our animal model, because they just cannot see the heart, and because that humans, but that zinc level and the same like conclusion and our animal models. So we continue to use the HT2 knockout mice and to see the like a different complication, different model, and we published several works, and that is really convinced the like epidemiology study group, and they summarize the like published like a date, and finally narrowed down, and 27 publication is qualified. And what they found, and if they give the lower dose and each day and like 25 milligram and or higher than the 25 milligram, and over the time short than 12 weeks or like longer as 12 weeks, you can see that the fast blood glucose and fasting, you see that have a significant lower than reduced, and it's very good. And the compared the time, the means the lower dose is good than the high dose, and the long time, and then the short time, you see 12 weeks. And other measurement is same thing, and that really from clinical convincing thing, and really protect the heart and reduce the glucose and the complications. So I try to publish several editorial to call or like ask the attention. We use the zinc can fight with diabetes, and we can fight with the diabetes complications. So after I cover and then like work on this field, what I got. So I got them invited from the Nature like review cardiology, and they asked me to contribute to a review. So we write a review and regarding the mechanism and the preclinical study and clinical observation to try to talk about the thing and field. So more fun part is that, and 2 years ago, like 2022, and they have 3 publications. They talk about ask who work on this field, and you can see the big ball is who is me, work on the diabetic cardiomyopathy, and of course like University of Louisville is a big ball, and when they summarize the field, and most like the publication they work on like that is a diabetic cardiomyopathy Nature's feature, but zinc is my features and signature is zinc supplementation for diabetic cardiomyopathy field. And so that is makes me very feel happy. And similar, and I work on this field, and they have one society called Chinese American Diabetes Association, and each year they have one achievement award. And that is set up in 2016, and I was like a second awarded for that award. And so I also invited by the different journal as chief editor, sub-editor in this field. So more fun, and one day I got an email, and they asked, Lu, go to that website and give the diabetic cardiomyopathy to see what's going on. So when I go there and I see it's my name in the top, and that is a worldwide diabetic cardiomyopathy expert, and you see my name is, and the second one is where known people who work on this field is like Australia. But that is 2 years ago. But recently I work on cadmium, and you see what? And you see I got second because I started to slow down. So I need to catch up again. Yeah, and that is for specific for the diabetes field. And actually, I got an email, and they have the website and best medicine scientist. You can get into the whole world or each university or a definition. One day I gave the University of Louisville, and you can see, and they have a 15 and Sean and our faculty here, and Robert and Ollie and Dr. McLean, and so that is the top 2. And my name is in there, and as 13 on the total 15. At least it's not that bad, and high index is 82. So it makes me very happy. So each journey and for different kind of research, and I really enjoy it. So and based on that, give you some idea in the future if you think about work on diabetes, and you can talk to me and think about the load of radiation, and I'm here. And also kind of cadmium, and also can provide us any experience. So thank you so much for your attention. All my work and is based on a lab member and the trainee and also collaborator and the foundation. So thanks so much. Oh, any question? No question. Oh, okay, sure.
Wonderful job. I had a question about your cadmium work. So you used 500 ppb and 5 ppm.
5 ppm.
So how does that compare to human exposure, where the maximum contamination limit set by EPA is 5 ppm?
The 5 ppm is not in the animal bodies. Actually, that is drinking water. And most through that bottle is a 5 ppm water, and we use 6 months, and we check the blood level, and can measure that. Its candle is a heavy smoker, and the cadmium level in the blood. And we also found in the tissue accumulation not that huge, but from the drinking water, you heard it look like it's high, but is in the body is not that high.
Thank you very much.
Sure. Sure.
So for the low dose radiation portion, so basically you want to the dose of that low dose radiation that would provoke an adaptive response beneficial. What's the assessment or the regimen like for, say, patients coming in with different diseases, or is it not worked out yet? Or is it more so they all get a low dose, but you may get a different dosing regime,
That is a very good question, but also it's a very complicated question, because radiation applied to clinical is have to be very careful. And for example, they have a lot of the gene mutation symptom. If the person have a gene mutation and that is a mutated this enzyme for gene repair. So that means that patient, even low dose radiation, you cannot give the low dose radiation treatment. This still causes the gene damage, but in the individual, they don't have the repair mechanism. They're still very high sensitive for cause of phenotype. So that is for patients we have to kind of precision medicine. You need to look for their gene and sequencing, and if there they have some gene repair and lower. For example, Dr. Zhixian and in the New York some hospital, I forget, and he is working on the radiation oncology department. One day they have routine treatment, one patient, same dose, and got quickly and kind of the system called kind of vomit and kind of the radiation symptom, because in our body have all the systems that have a cell proliferate, and that is very sensitive. That opens the bone marrow blood system because they keep proliferate. So and the intestinal system very sensitive because that keeps and remove and kind of replace those cells and make the intestinal absorption very good. So both systems very sensitive. If they have gene mutation, even 2 grade, that is supposed normal people can tolerate, but that is already caused intestinal mass damage, and that got area and diarrhea, and that lose the inflammation and got a whole body sepsis. And later that patient died, and they before they die and they got the skin do the biopsy, and they building the cell line, they found a couple of the gene repair enzyme in that individual deficiency. So that makes them to in clinical treatment, even normal tumor patient and cancer patient, it's better also have the screening for gene mutation. So that is how low dose radiation applies the clinical. So that is one question. And also the different kind of person, the is healthy or not healthy, and there also is affect the low dose radiation and impact, because that low dose radiation and like I mentioned, theory any dose of radiation is harmful and damage. For the damage response or homeostasis, that also is based on the DNA damage amount or cell damage and other part. But DNA damage is most severe as a key question for the radiation field. Small DNA damage cause a 15 cell have a genomic damage, instability, but that is okay. And our system removes the cells, apoptotic pathway, DNA repair pathway. They can fix that issues because they have a P53. When we got DNA damage, P53 turn on and makes the cell cycle stop, arrest, repair, and if that cells repair very well, go on, and if not, apoptotic cells death, remove that. So we have a small amount of damage, but turn on the protective mechanisms. So make that usually we are very to give you an example. I worked on in China in 1993, go to Canada, and stay there for 6 years and go back to China. So 6 years, I don't have used any medicine. I'm not got a cold and not any disease. Not don't need to go to hospital to see patient, doctors. But when 6 years back to China, got very severe and sick and fever and kind of because in China they have air polluted and the environment polluted, making your body strong. All the protect mechanism turn on in the maximal level to protect your body. But in Canada, everything too pure at that moment. And less people, air is very fresh, and the food is very safe. But six years, all the protect mechanism shut down because they don't need it. When I go back to China, somebody got knocked down. So that is our body has the capacity. So the low dose radiation causes couple of DNA damage, causes couple of cell death. It's not good. So we talk about how the affect the cycle time. So you see that the cycle time really protect, but not pure is just turn mechanism and not damaging. That's still. So we have to think about the target, the gene mutation or not. If normally it's okay, they can tolerate shunt protect mechanism. Thank you.
Question again about low level of radiation, which is very interesting topic and a little bit controversial. So you're showing that low level of radiation very beneficial and might prolong life. But how do you reconcile actually the life path that pilots and people in aviation is flying frequently and getting low dose or medium level dose of radiation with less and get more sick?
Yeah.
Is this because of dose of radiation or because of intermittent exposure? What's the thought?
So for the space and the radiation, actually space radiation is not belong to the low dose radiation. And low dose radiation is dose of low, so low, and also the quantity. For the radiation that have alpha, beta, alpha and particles, and beta, gamma rays. And for X-rays, gamma rays is that it's called low energy radiation. That all is like that is the space that is the high energy radiation. High energy radiation is further lower, probably 10 microgray or 5 microgray can have the same effect with the low energy radiation, 50, 70 milligray. So that is a totally different. And for the pilot, and if not go to very frequently from New York to the California, and that probably already got kind of half dose of the CT and dose. And if you are day by day, and probably not good, but once a week or a couple of days or once, it's good. And I actually each annual enzyme, basically enzyme in here, my lung have some kind of chronic disease from college or even younger than that, long time. I know that's no problem, but I can use that reason ask them to give me CT. So I'm very happy to take a PT to take a yearly or a couple of years for one CT. It's no problem, yeah. And for space, that is not belong to that field. This is too damaged. And you have to think about other strong medicine to protect. Like we can think about the sulforaphane and make your nerve to turn on and other potential prevention.
There are no questions online?
Oh, okay.
Oh, there are none, so thank you,
No?
Dr. Guy.
Oh, thank you. And we need to stay here.